Yeah, so I'm Dr. Zuckerman. I'm an orthopedic oncologist at City of Hope. And I'm going to talk to you basically about bone sarcomas. And I'm going to progress to the treatment to some of the newer technology and treatments that we have, including limb lengthening and bone transport that we can do after sarcoma resection. Thank you for having me. I've been listening to all the talks and they've been great. And I think some of the stuff that I would mention is very similar. Let's see. Advance that. Okay. So first of all, just what is orthopedic oncology? Because we're a very rare breed. There's only about 200 to 300 in the United States at any given time. So we're typically organized at major cancer centers or major academic centers. There are a couple of exceptions with that, but for the most part, we're very localized to bigger centers because of how few of us there are, and because sarcoma overall is a rare disease. But we treat not just sarcoma, we treat both benign and cancerous tumors that can be in the arms and legs and pelvis. This includes both bone and soft tissue. And the focus in general for orthopedic oncology is, again, limb salvage surgery. So why would someone see an orthopedic oncologist? So if you know somebody, let's say they had breast cancer 10 years ago and they've been in remission and it had never spread or something like that, and something pops up in the bone, what many people may think is, oh, the breast cancer must have suddenly spread. That's not necessarily true. So anytime there's a new lesion in the bone, even with a person with a diagnosis of a cancer previously, they should see an orthopedic oncologist, because it may be a different cancer. It may not be a breast cancer, it may be lung cancer, or it could be a sarcoma. And I've seen many patients, it's much more common than you would think. I see it more often because it's what I specialize in. But this is extremely important, because the difference in treating someone with a bone lesion in breast cancer versus something else is much, much different. The other issue is whether or not you need a biopsy. There are some things that are in the bone that I can look at an X-ray and MRI and tell you, no, this is something that we can just watch. This is not something that looks like a cancer. And there are some things that we can do with that, and that can be very important in terms of treatment. The other issue is if someone's having more pain and they have cancer. So if the cancer is growing in the bone, you can think of it sort of like a cavity in a tooth. And as it grows, it eats up the bone. And at some point, the bone becomes so weak that the bone can break. So that's the fracture risk. So whether or not someone might break their arm or leg because of a cancer, that's why they would come and see an orthopedic oncologist to see if they need any sort of treatment for that. The other thing that happens is there are side effects of cancer treatments. And most commonly with metastatic cancer, getting steroids or bisphosphonates, things like that, can cause problems in the bone that you may need to see an orthopedic oncologist for. So why is it important to see an orthopedic oncologist? And I think everyone has sort of emphasized why it's important to see a sarcoma specialist, is because, again, in terms of orthopedics, in terms of the bones, the orthopedic oncologist is the specialist for sarcoma. And that's because even if you don't have a sarcoma, different types of cancer requires different treatments. And we usually have more of a knowledge of that. Some respond really well to radiation and may not need surgery. Some respond really well to systemic therapy, chemotherapy, immunotherapy, and that may be an option. Or it may be something that needs a combination of those types of things. And then certain cancers, not talking about sarcoma here, such as renal cell, kidney cancer, there's actually an improved prognosis if we can take them out like a sarcoma. So there are multiple studies that say if we have a kidney cancer that's in the bone, if we can take that out like a sarcoma, all in one piece, then people do better, they live longer, they have a better quality of life. The other issue, again, because there are so few of us and we're concentrated in academic centers and cancer centers, is you're more likely to have the coordinated care you need. You're gonna be able to see someone who's an oncologist that specializes in sarcoma, radiation oncologists, if you need a thoracic surgeon, surgical oncologist. Typically, orthopedic oncologists are at centers that have all of these people. And then again, cancer is what we take care of. In terms of an orthopedic surgeon, some training programs do not even have an orthopedic oncologist affiliated with it. It's not a requirement to get through an orthopedic surgery residency. So you need someone with that special training who knows how to take care of cancer patients. And there are multiple studies, and this has been repeated over 20, 30 years, that the most common reason to need an amputation is just an improper biopsy or surgery. So if someone else does a biopsy and it's done improperly, that puts someone at risk for needing an amputation. The other thing is, well, what if I choose an amputation, or what if I need one anyway? Can't someone take care of that? As Dr. Sang mentioned, it's very important to get negative margins, to get the tumor completely out. Just because you have an amputation doesn't mean the surgeon is going to get all the cancer out. And so even an amputation can be much more complicated when a sarcoma is involved. So given all that, limb salvage surgery is pretty much the standard of care, and we can save people's limbs in 90 to 95% of the time. It's true, though, that that isn't always necessarily the best option. Sometimes an amputation is a better option in terms of function, not necessarily the mental aspect of it. You know, having an amputation, losing a limb is a big deal. But the majority of the time, we do not have to do an amputation. Traditionally, with limb salvage surgery, the complication rate was very high, but over the past 30, 40 years where it's really been refined, we have much more improved techniques and implants. We're able to do joint sparing surgery. So instead of taking out the person's knee or hip joint or elbow or shoulder joint, we can save those. And now what we're getting into is looking at the problems that can happen more longer term, such as correction of people's limb lengths or deformities that can happen either from their treatment or for other reasons. So these are just a couple examples of the types of implants. I'm going to show lots of x-rays, try to describe them to you. So on the left here is a shin bone, a tibia, and this is a metal replacement that basically replaced this part of the tibia. And it's fixed with some bone cement, sort of like fixing a cavity in a tooth at the top and the bottom, and it replaces this and the person can walk on it. This is a patient who had their whole thigh bone, their whole femur removed. And this is actually an implant that was able to expand and grow. This is a child who was still growing. So their opposite leg is still growing, but since we took out the parts where the bone is growing in the thigh bone, we need some way to get their leg lengths the same. And this implant actually, with just using an electromagnet, something you would put around the leg without having to do a surgery, was able to expand this and help the metal to grow. So basically helping the new quote unquote bone to grow. This is an example of using donated bone. So right here is where donated bone allograft begins, and it actually goes down to here. And this is sort of the traditional way of fixing it, with either using a rod that goes inside the bone, some screws holding that rod and holding things down here, as well as a plate with some screws on the side. And the biggest thing that we need here is to squish the bones together. Getting that compression of the bone is what gets it to heal. And then something that we typically don't use in orthopedic oncology, especially when people are getting chemotherapy and other things, this is an external fixator. So if you've ever seen someone who's got some pins coming out of their legs with this big contraption, this is something that's traditionally used for correcting deformities, or what's called distraction osteogenesis, which is basically forming new bone. So here's just an example of something that someone might have done for metastatic disease. And this is just to show you a progression and the difference of how different things are treated. So this is the thigh bone, the femur here, with the hip joint up here. And right here we see a hole in the bone and a little fragment of bone out here on the side. So this is some cancer that got into the bone here. And this is actually a lung cancer. So the patient could get some radiation and other things to this, but there's not much bone left over here. So they're at high risk of breaking that bone. So what we do is we go in, we take out the cancer in that area, and then we put a rod inside the bone and put some bone cement to help fix the bone. And this makes it so the person is able to start walking on it. We don't have to worry about it breaking. They can get back on chemotherapy, immunotherapy, have radiation to the area to kill any of the cancer that I've left behind. But I'm not getting 100% of the cancer out by doing this. I'm scooping this out. You can see there's still some bone here. So this is a smaller surgery with someone who has metastatic lung cancer that needs to get back on their treatment. This is not a curative surgery. So this patient is going to rely on that systemic therapy and that radiation to kill the rest of the tumor. This is not what we want to do in a sarcoma. In a sarcoma, we need to take this completely out. Now here's an example. This is actually renal cell kidney cancer, but I only do it to show the difference of what can happen, because typically if someone puts a rod inside a sarcoma, we're not going to let it progress to this point. But it was the same sort of thing. They started out with just a small little spot here in the bone. They were at risk for breaking, and the patient was seeing a regular orthopedic surgeon, and they put a rod in it. Now the problem with putting a rod in it without even taking part of it out is you've now spread the tumor. So this has allowed it to grow. Kidney cancer doesn't always respond well to systemic treatment or radiation, and it just kept growing and growing and growing. And now you barely have this rod holding on to the hip bone here. So what ends up happening is the patient needs a bigger surgery to take it out all as one piece. So this would be more of the type of surgery that we would be doing for a sarcoma, where we're taking out a larger piece of bone, all in one piece, getting all of that cancer out. So what can we do with newer technology with it? So this is a patient with an osteosarcoma of the tibia, the shin bone. Knee joint is right here. This is the fibula, the smaller bone, and then the shin bone here. All this sort of wispy white stuff, this is all new bone that's formed, and it's mostly in the back here, mostly in the back of the bone. We can see it looks like it goes up to about here, so it actually doesn't go up to where the knee joint is. So can we save the person's knee joint? Is there any way to cut out the bone here still with getting a negative margin and then replacing it with something without having to do a big giant knee replacement? So one new technology that we're using is 3D printing. So what we can do is we can take an image, basically use a CAT scan or an MRI, and basically make a model out of it. And in this case, the red part here, that's where the cancer is. So we have to get that all out with the bone. Side view of it, so this is the front of the bone, this is the back. We can see most of it's in the back here. And then what we can do from this model is print an image, 3D print something that will basically look like what we're saving and what we're taking out. So this is the back part, we're taking all of this out, and this is where the cancer is coming out. From that, we can make a jig, a cutting jig, similar to what people would use in woodworking. We do our surgery, we get all around it, and then we put that up to the bone and we cut the bone to get that out. And then in this case, it was fixed with multiple plates. And we can see on the side view here, this is the front view over on the left with the side view next to it. We can say we just saved just a little bit of that bone, but we were still able to get the cancer completely out. We had negative margins with this cancer. And we can see the donated bone, which we also used a reverse cutting jig. So basically the same jig that we used to cut the bone to get the cancer out, you make one that cuts the donated bone so it fits in there as best as possible, and put that in there and fix it with multiple plates. Now the problem with donated bone is that it doesn't always heal. It's dead bone, and you're trying to get your own bone to grow into it. And so we can see here between the first two images and the last two over here, the top part healed really, really well, but the bottom part here had to have another surgery to get it to heal. And 5 years later, the person walks normally and is cancer-free. So this is something where we can use a technology to save people's joints. One other technology in my disclosure is that I'm a consultant for the company that uses this particular nail, and that actually happened because I started using their nail and they saw what I was doing and was interested in trying to figure out how to make this better for cancer patients. What this is actually a telescoping rod that goes inside the bone. And people are using this for limb lengthening. Typically, if someone's born with an arm or leg that's shorter, they can use this implant to lengthen their arm or leg. And some people are even using it for cosmetic lengthening to get taller. But basically, it's a rod that goes inside the bone. It has a magnet in it that powers a motor. There's a little remote controller that's used on the outside. So at home, someone puts this little magnet that interacts with the magnet that's inside the rod. They activate it for a couple minutes, usually 2, 3, or 4 times a day for a couple of minutes. And that magnet powers the motor. And what it does, we cut the bone between where the rod is fixed, and it slowly moves the bones apart. So your body thinks that the bone is broken, and it does what it naturally is supposed to do, which is heal that bone. So as it slowly moves, average about 1 millimeter a day, the body now forms more bone in that space. And what that does is basically recreates the person's own bone. And over time, we can lengthen several centimeters with that. There's another similar implant that basically transports bone. And this is an example. It's fixed up here. The bone is cut here. And then there's a defect down here. So we probably took a cancer out of here. And what we're going to do is move this segment of bone into that space, and then to get it to heal down here while the new bone is forming up top. And over time, about 1 millimeter a day, a little bit less for the shin bone. We're moving that down. It's forming new bone. And then when we get to the bottom, it's healed to the bottom. So it's basically the person's own bone. We're avoiding using large metal replacements, which the problem with that is there's an infection risk. It's made of metal. It wears out. It may need multiple replacements, different things like that. So in theory, this is a newer technology. So in theory, having your own bone is going to be better than using donated bone or using a metal replacement. So let's take an example of how I first started using this technology, and I used it with donated bone. So here's a humerus, an arm bone, and this is where the cancer is. So we got to get that out. That's the most important thing with all these surgeries, is you have to get it completely out. Otherwise, it's going to come back. It's going to cause another problem. So we basically cut the bone up and down here, and this is where the donated bone is. And because this thing can telescope, it can actually go both ways. It can both expand and it can compress. So we can use this to squish it together. And as I mentioned, the squishing together is the most important thing to get the bones to heal. So we squish it together. And usually what happens is one side heals a little quicker than the other, but we start seeing that, well, it's harder to tell where that line is, and this square bone now is remodeling to the patient's own bone. Here we still see a line, but we see it more curving a little bit and looking more normal. And then finally, after everything is healed, we can see that, yes, this is healed together. It's getting a little harder and harder to tell where the top part, where the new bone starts and stops. So this is one thing we can do with donated bone. So let's take that a step further in someone who's still growing. So this is a child. This is where the bone is still growing down here. These are the growth plates. This is the knee joint. So this is the thigh bone. And this patient had a high-grade pleomorphic sarcoma that went down to about here and way up here, which we can see on the MRI. So even though on the X-ray it looks like it's just here, it's actually going pretty high up here, and it's going pretty low down here. So it looks like we can save probably from about here down, and we want to get some space between where the cancer is. So we're probably going to go about up to here with cutting the bone with that. So we do that. We put the donated bone here with the rod that can compress. So the donated bone goes from almost, a few inches below the hip joint to a few inches above the knee joint. And over time, what we see again is just tremendous healing of this, both top and bottom. I took out the screw down here to see if his bone would still grow, but because I squished the bone did not grow anymore. And so he did really well and grew as a child his age should grow. And what ended up happening is he was about 6 centimeters shorter on this right side versus the left. So what we do then with the same rod that's in there, we cut around the rod through the bone. So we make a cut through the bone here so it can start to move. That's the front view over here and the side view over here. And then we start growing new bone. And this is the new bone that we're growing, the front view here, the side view here. And then when we're done with the growing, basically all this is all his new bone. It's incorporated well with the donated bone. It's really hard to tell where that is. And then the rod, this is where it's all telescoped. So this is how much he's grown basically with that procedure. And then he gets the same limb lengths. He's as tall as he was supposed to be, and is able to get around and do what he wants to do. So one thing to notice is we do seem to get really good healing with this. This is another example just to show the healing. Even when, traditionally with plates, we only think a millimeter or two of the bone grows in. With these, sometimes we're getting this tremendous amount of healing where the body is incorporating into this donated bone. So overall, this is a promising treatment option. So what about someone who's had some other type of, surgery done and now has a limb length discrepancy? So we can use it for that. So this is a person who had a Ewing sarcoma of their pelvis and did very well. They had a good surgery that saved their leg, and they were actually fused. The thigh bone was fused to their pelvic bone here. But there were a couple of issues. This patient got referred after, about 10 years after they had been treated for their cancer. And they had problems where their leg was just curving in a little bit. It wasn't able to bring it out very far to the side. So they were sort of scissoring with their legs rubbing together. And this leg was noticeably shorter because basically this is where the top of the hip bone should be. So over here, it's about up here. The top of the hip bone is gone, but it would be about here. So what we can do is we can correct that. We can straighten out that part of the bone there. And then we can again use this growing rod to again grow the bone and basically fill that in with the patient's new bone. And what that looks like the before and after, this is the before. So you can see the leg here, they're standing on something so that they're not tipping over. But this leg is much different in length. And then we fix that, we straighten that out. So the curve is gone, their leg is straighter, and their leg lengths are the same. So we can also do that. Let's say someone had a replacement, and in this case, the person had multiple replacements, and they were seeing me because their leg was much shorter. And this one here is the right leg. They're just reversed on the x-ray. So this is the right leg, this is the left leg, and we can see the knee is way above the other side here. So a pretty big difference. So we can't do much with this right side. So we're gonna do it, or the femur, the thigh bone, we're gonna do it with the shin bone. And we do a similar thing where we're able to lengthen this bone. Their knees will still not be at the same height, so it's not perfect cosmetically. But in that case, you can get their leg lengths the same so that they don't have to use a large shoe lift or custom shoes, less risk of back pain and contralateral other side knee pain and things like that. So it can be very life-changing for someone with this. Other things that can happen is we can correct deformities that typically can happen just from treatment. This is a patient who had a Ewing sarcoma in the thigh bone here. And with kids, what sometimes happens, we do a surgery, and whenever we do a surgery, sometimes their bone grows quicker or grows slower, and that's sort of what happened on this side. So this is a donated bone that healed in, but you can see the knee joint here, it's sort of lopsided. And what ended up happening is one side of the bone started growing quicker than the other, and same thing here, instead of being straight, it's curving a bit that way. So we can take that out and we can correct it, we can straighten out the bones. Because the knee joint hadn't grown properly, the patient also had one leg longer than the other. So we fixed that with this rod to start growing. And this is a before and sort of during treatment. So we got someone who's knock-kneed, their knees are overlapping here, and their leg is shorter, their ankles are down here. We straighten that out so they're not knock-kneed anymore, and this is during the transport process. And we get it to a point that they've now healed with their own bone and they've incorporated their donated bone very well. So a couple other ways we can use it is we can shorten the bone in some cases, take out the cancer here. Instead of putting something in, we basically shorten the bone so the arm is shorter. We can do that up to a certain amount of distance. And then we slowly start growing the bone back. So we get their arm back to their original length. Another way of doing this, and this is more that bone transport nail, so we're transporting bone. So here's where the cancer starts in the thigh bone, goes about here. So we're taking all this out. We put in this rod. Here's where we've taken out the cancer. We've cut the bone here, and this is the piece of bone that we're moving down. We got a screw here that's going along a track. Same thing, they put the magnet right over this spot. And what we see is we move this piece down. So we're going to fill in that gap, and we've got all this new bone that's forming in that space. And over time, this is what we're having. This isn't quite to where they've gotten all the way down, but all this is their own new bone that's formed there. We can take that to one more sort of extreme way of trying to preserve someone's knee joint. Person with an osteosarcoma here, bone is growing here. So we're going to take out the bone from about here to right below where the bone is growing. We're going to save just a little bit of bone there. And again, we're going to transport some bone down. So this is where we took out the cancer. We made the cut here, we're moving it down. And as we move it down, that new bone is forming up at the top here. And we get the bone to dock down at the bottom. So again, this person's thigh bone becomes their own again.
2 minutes, please.
So basically, you know, we've got techniques and technology that continue to improve. And because of that, it's not just that we're able to do limb salvage surgery and that's the standard of care. We're moving towards things such as joint preservation, which should help the person be able to do more of the activities that they want to do. Also correct limb length discrepancies and deformities, things that can happen when the person had a very good treatment outcome with their surgery to get rid of the sarcoma. But sometimes things, you know, sometimes the leg may have to be a little shorter or other things with that to accomplish that. And last thing that I want to end on is basically all these things are things that are done by an orthopedic oncologist. This is why it would be so important to see an orthopedic oncologist from the beginning of your cancer treatment through the end. And thank you very much.
That was.
Thank you very much.
Great. I learned so much. Great pictures. Okay, let's see if we have any questions. Okay, let's see. If there's soft tissue involvement in the need of surgery as well as bone cancer, does a sarcoma surgical oncologist remove all the soft tissue cancer in a separate surgery, or does the orthopedic oncologist operate in a combined surgery? So,
yeah, so typically, and there are some exceptions to this, if there's something in the same place that's in the bone and the soft tissues, it's started in the bone and grown out to the soft tissues. There are some rare cases where if a soft tissue sarcoma is big enough, it can start to erode into the bone. Sarcomas typically grow the path of least resistance. So your body has holes in the bones where blood vessels go and things like that. And so the bone where it's not as hard and has those little holes, it's going to be able to grow out into the soft tissues. An orthopedic surgeon, an orthopedic oncologist is trained for both bone and soft tissue sarcomas in the arms and legs. So they're typically going to do that. The part where we typically combine, there's a couple exceptions in the extremities, but the pelvis or anything like that. So when it gets into the pelvis, a lot of times there may be something where it's close to someone's bowel or bladder, or maybe more in the retroperitoneum. So those are the times that we usually combine operating together.
okay. I think those are all the questions. Let me see if there's anything in the chat. I think we've answered. Is it possible to get a negative? I guess we'll ask this to Dr. Singh, but is it possible to get a negative margin, or we can also negative margin when the tumor is sitting on next to the bladder?
Sorry, negative margin if it's next to the bladder?
Oh, there are some, yeah. Actually, there are some more questions, sorry. Yeah, so maybe you could talk about that. So I guess that question would be, you know, you could still get negative margins. I guess you'd have to, sometimes patients have to have their bladders removed.
That's right. I mean, strictly speaking, sometimes to get negative margins, you have to resect that portion of the bladder that it's touching up against. But I think the bigger question is whether that's necessary in all cases. And we're talking about pelvic sarcomas here, and some of that depends on the subtype and others, and also what part of the bladder is involved, whether it can tolerate a portion of it being removed. So it really depends.
Okay, here's a question. On the allograft x-ray at the beginning, what was the distal end of the femur? Were you able to salvage the knee, or did you also put a TKA? There was the distal end of the femur had different shape. Great presentation, learned a lot. I've lived in ortho for 30 years.
Yeah, so on all those allograft cases and the bone transport cases, we were able to save the knee joint, and they didn't need a knee replacement. That doesn't mean they may not need it in the future, which is always a possibility, because sometimes the blood supply may be a problem or other things like that. But so far, 5-6 years out with those patients, they haven't needed to have everything done. They have their own knee. So that's sort of the purpose of those surgeries. If we can get that negative margin in an acceptable margin, then we can save the person's joint and prevent them from needing a knee replacement.
Perfect.
And then
Thank you so much. I think that's all the time we've got, unless you got one more. And then we got one more.
Yeah,
we can do
one more, because this one is a good one. I realize, not that they are good, but yeah. Okay, I realized this was limb preservation. However, in the cases of amputation of the parts of the hand due to sarcoma, are there advances in any prosthetics or regrowing bone for replacing that ray finger?
Yeah, nothing that necessarily is better. You know, there are prosthetics, and they are doing things where they can actually respond to the electric impulses that go through muscles and different things like that. So there are things coming out probably, you know, in the next 5-10 years type of thing. The thing with the hand is that, you know, what a surgeon will tell you is that your function can be very good without having all your fingers. And so sometimes having a prosthetic or something like that, the function isn't as good. It can be more cosmetic. But there aren't current things for just fingers. For the hand and stuff like that, it's more what people are focusing on. So they're getting more and more better prosthetics for hand function. And probably within the next 5 to 10 years, those will become more common.
Perfect.